Okay. Well, Salvete was my start, inspired by Milan. Unfortunately, it's all the Latin I can remember, but I do remember that it means be healthy or be well, which seems like an appropriate way to say how delighted I am to see everybody here, those who are there in person, and also those who are there virtually, because of this health crisis that's been going on for nearly 2 years, which I find at once ironic and highly revealing. And I was thinking that in some sense, we're hoping the conference will go viral. And in another sense, we're very much hoping that it won't. Um, but in the positive sense, what we're trying to do is get some attention to an issue and some solutions for an issue that's actually been going on throughout my public policy career. And I think people are finally ready to talk about it. And it's, to some extent, it's kind of a melancholy feeling to think about how long we've been fighting over some of these issues without achieving anything except gray hair and sore hips, which I guess might have come along anyway. But one of the things that I find very hard to believe is that I wrote this piece, "You Will Die Like Dogs," 28 years ago. I was going to say that I remember it as though it was yesterday, except I'm actually having trouble remembering yesterday. This was something I wrote for the Fraser Institute's Old Fraser Forum, so long ago, as you can see, that I didn't download it from the internet. There actually wasn't an internet. I remember we thought fax machines were cool back then. So technology has advanced an enormous distance, but it seems as though when it comes to the debate, especially on healthcare, we haven't advanced at all. And that is a sort of depressing thought. I'm also a bit depressed to think that on some important issues, it seems to me we won the battle of ideas 2 decades ago and policy didn't improve. And that's disturbing because it raises this very real danger that bad incentives beat good ideas. And if that's true, the problem is even worse than it looks, and it looks pretty bad. But the other thing that has certainly been an issue when it comes to healthcare is that there are things we either can't debate anymore or else we never could debate them. And healthcare, and throughout my professional career, has really been in the you can't debate it category. It's been like trying to light wet wood. And it's interesting because there are topics. Gender is certainly one of them now, where starting a fire is all too easy. One ill-chosen phrase and you go up in flames, your career is over, and your personal life might be in some jeopardy as well. But there are others, and healthcare seems to be one of them, where you could say anything. It doesn't matter how inflammatory, and you wouldn't even get a wisp of smoke. Nobody would bother to insult you. Nobody would threaten you. Nothing at all would happen. Beyond the skill of elf or even dwarf, for those of you who are Tolkien fans. But I do think that the wood is now dry. I think that we're actually in a position, including at this conference, to get a blaze going that will throw some light on the subject and give us some life-saving warmth rather than destructive heat. The starting point here, and it's amazing that I would actually have to start with this, but since I do, I'm going to. Our healthcare system isn't working very well. And it's funny, I remember, this is another cartoon that I remember as though it was yesterday, which I came across way in the past, but I've always kept it. It's a Born Loser cartoon where he gets on this elevator and it stops. And he turns to the guy next to him and he says, "Well, it looks like we're stuck between floors again. It usually takes a couple of hours to get these things going, but at least this time I've got somebody to talk to." And he gets back the answer, "Rotsky mein Schnickelblatt Nudnik, Squabbledood Dicken Schnitzel Vogel Glopperdung." And if you try and tell people, and this includes politicians and journalists and activists and people who aren't currently sick or don't know anybody who's sick, that Canadian healthcare doesn't work very well, you might as well have said that to them. They hear sounds coming from your mouth that remind them of speech, but convey no ideas. And I know another of our speakers has this project for fixing healthcare that's going to start with the idea that we must stop uttering falsehoods about it. And that, I think, is a very important point. I'm not going to steal his thunder, but I am going to suggest that there are 2 falsehoods about Canadian healthcare that we've got to clear away in order to get to the fireplace. And the first one is that it works so well that it's the envy of the world. And the second one is that it's free. And there's a third one, which is tied to the first. Maybe it's a subset, that the only alternative to our current system is awful US private healthcare. And again, this is a subject on which you often feel that the speaker knows less than they do about the Panov-Botvinnik attack. Um, the American system actually has some very good features and it has some very bad features. And a lot of its bad features are due to the fact that there's too much government involvement. There are enormous, horribly expensive, very poorly designed government programs in the United States that eat up hundreds of billions of dollars every year on healthcare. And so when you're trying to get the fire going here, that's one of these things you're going to have to keep swatting away in order to focus on what you're really doing. But to return to the larger thing that must not be said, that Canadian healthcare works so well, it's the envy of the world. It's nobody other than Canadians even thinks our healthcare system is interesting, never mind praiseworthy. Mordecai Richler, and there's a certain irony in this, coined the phrase world famous in Canada. And our healthcare system is world famous in Canada. When people elsewhere are looking at their own healthcare systems and thinking about what's good about them and what's bad about them and what they should try and do. And remember, every single OECD country has a very significant public system. It's not us, the United States, and uttermost darkness. There are all kinds of interesting models out there, all of them doing better than ours. Except the American one, it's, in some ways, yes, in some ways, no. But in all these other countries, they don't even use Canada as a warning. They don't say, okay, now in fixing this, let's not do what the Canadians did. Just nobody's saying, let's go down the American road, and nobody's saying, let's go down the Canadian road. We're simply not the wonder of the world here, and there are good reasons why we're not. And that, in fact, brings me to another subset of this myth. This idea that our healthcare system is moderate and centrist, that we have found the sort of sensible balance for which Canadians are famous and everybody else wishes they could do it the way we do it. And this is another of these weird things that tends to stifle discussion in Canada. There's a conceit that on virtually every issue, we are the moderate centrists. And, it's sort of like the lawyers pleading in the alternative that my client didn't commit the murder, Your Honor, but if he did, he was insane. So we say, well, our policy is absolutely the best. Everybody loves it. But in case it's not, it's perfectly ordinary and middle of the road, so we must be safe. For instance, during the COVID pandemic, we ran up debt as a share of GDP more recklessly than any other G7 nation. Our lack of an abortion law is not typical of civilized countries. It's pretty much unique in the world, except for China, and to some extent, if it has laws, as we use that term, North Korea. And, maybe that's an example that doesn't interest a lot of people, but it's curious that our efforts to exclude private care, including private insurance for publicly covered medical services, is once again more or less unique in the world, except for North Korea and Cuba. And whether it's a good thing or a bad thing is separate from the notion, is it in the middle or is it out at one of the wings? But if you can't even figure out what it is, you're going to have trouble figuring out more complicated things like, is it any good? And the same thing is true. I mean, we assume that our economy is more regulated than the awful United States, but less so than socialist Sweden. And both halves of that statement are probably untrue and certainly unexamined. But not here. Here, everything's up for debate. Everything's on the operating table except abuse and conspiracy theories. So we're going to keep the tone civil here. And we always have a problem at these conferences where somebody tries to grab the mic and start ranting about a plot. And if you do, we're going to shut you down. So don't bother with a tinfoil hat. I don't care what the subject. I don't care what the point of view. We're not doing that. What we're doing is talking about Canada's healthcare system, what's wrong with it, and what to do about it. And that means the other weird thing, but life is weird. We have to get rid of the idea that our system works. And when I say that, I mean, you can get excellent healthcare in Canada, especially if you're really sick or badly injured. If they get you into the ER and the doctors and nurses and others swoop down on you, you're going to get excellent care and you'll probably get it very quickly. And those are good things. There's no, it would be absurd to deny that these are positive features of our system and ones that everybody would like to emulate. And in fact, most people do emulate. But the problem is that our system in particular is in chronic crisis management mode. And every time they successfully meet a crisis, including getting somebody into the ER and saving their lives, it makes the underlying problem of bad resource allocation worse. Now, if I wanted to put everyone to sleep right to start the conference, I'd start talking about Friedrich Hayek. Because he pointed out that the great problem of central planning, and we have a centrally planned healthcare system, is that the planners cannot know enough to make rational decisions. They just can't know what's happening, and they can't know why it's happening, and they can't know what will happen if you change it. Again, Leonard Read's I, Pencil is Hayek reduced to readable form, talking about the incredible complexity of the manufacture of a pencil, of all the things that go into a pencil, from the lead, which isn't lead, to the ferrule, to the wood, which has to be cut. Trees have to be cut down, so loggers need chainsaws and coffee, and ships need to be made. Like, everything connects to everything else. And if you let price mechanisms drive people's decisions about where to put resources, the information gets decentralized in a way that people know what they need to know. The logger doesn't need to know what a ferrule is. He needs to know how much the gas for the chainsaw costs, and that he can find out. But central planners can't do that. So when they say they're going to make everything work, you wind up like the Soviets. You try to hold it together by just doing the same thing every year, but on a bigger scale. And the more technological change there is, the more innovation there is, the more your fixed configuration doesn't match what would be a good thing to do with the resources. And interesting, one example from the Soviet system that illustrates the problem, they had a lot of trouble switching from metal to plastic plumbing pipes because they set the production quotas for the pipe factories by weight. And as soon as you start making plastic pipes, you miss your targets disastrously, not because you're an idiot or a layabout, but because the targets are encouraging the wrong behavior. And healthcare is a very dynamic field, and more resources are pumped into it, as was true of the Soviet economy. You know, they really did win Khrushchev's race. They produced more oil and steel and cement than the United States by 1980, but then they dumped it into a bottomless pit. And speaking of which, one of life's rules is that you have to be willing to be lucky. And I'm always willing to be lucky. And so while I was drafting this speech, Tom Harris of the International Climate Science Coalition emailed this chart. And this, to me, I don't want to end up taking hours to talk about all the evidence that our system doesn't work, but this is a really revealing statistic. And I went back and checked the source. Yes, this is legit. Hospital beds per 1,000 people in Canada from 1976, 10 years after we brought in the Canada Health Act, down to the present day. What on earth is going on here? I'll tell you what's going on. A steady, relentless decline that nobody intended, nobody wanted, and nobody could stop. At least they couldn't stop it without rethinking the fundamentals, and that's what they weren't willing to do. And, you know, if you had the stomach for it, you could take all the promises politicians made, including, remember Paul Martin's Fix for a Generation? You could put them up chronologically along this chart. And you could note that nobody who was anybody would admit there was a fundamental structural problem. And you could also put up, you know, waiting list statistics against hospital beds per 1,000. And this would make things even worse. You know, life is like golf. It's never so bad it can't get worse. And Canadian healthcare is a classic example. Imagine putting a chart of total spending on healthcare in Canada, spending per capita and spending as a share of provincial program spending next to this, and then ask where on earth, or possibly some other jurisdiction, all the money had gone. Because we do spend astronomical sums on healthcare, and yet the result just keeps getting worse. Which brings me to the second thing that they must not say, which is that our healthcare system is free. And so people keep using this word, but it doesn't mean what they think it means. Our system consumes an enormous quantity of resources. And by resources, I don't mean primarily, you know, tungsten or something. I mean, it uses up people's time and effort. It consumes the energy of skillful, dedicated medical professionals in staggering amounts. And yes, it also uses up, you know, the machines and the power and all the things that go into running hospitals and doctors' offices. A very large proportion of our productive activity is consumed by our healthcare system. There's no way it's free. It's not even free to the users. But at least it's not free to the taxpayers. Some people, if their income is low, probably do get their healthcare more or less for free. But somebody's paying for it. Things aren't free if somebody else is paying for them. And Healthcare, in fact, is getting close to 40% of program spending in nearly every province or territory, and it keeps going up faster than inflation. It is a really serious problem. It's not a matter of keeping it if we want it. It is a matter of something that is falling to bits and is draining the budgets dry. Now, I found this a slide on a Statistics Canada website, and it actually looks kind of reassuring. Here, health is the dark blue thing off to the left, and there's 40%. You see, oh, well, it's really only near 40% in a couple of places, a couple of the Atlantic provinces, even in Ontario, where it looks like it's down around 32%. Well, this is misleading in a couple of ways, and one of them is the red line. It says general public services. That includes interest on the debt. I'm not sure that's a general public service, but the point is you have to take out interest on the debt to get program spending. And if you do that, it pushes the numbers up. But it's still kind of weird because the red one is only 10% of Ontario public spending, at least back in 2019. Sorry, interest is only 10%, but yet the Financial Accountability Office of Ontario reported that year that health spending is 41% of total program spending in 2018 to 19. So despite the Statistics Canada chirpy graph where it's at 32%, which would be pretty bad anyway, a third of all spending on health, so much for free, the real number is considerably higher, and it's one of those things you're not really meant to talk about. And here's something worse. This is also from the Financial Accountability Office of Ontario. Not all bureaucracy by any means is useless. This is worth having, though not because it will make your breakfast taste better. This is based on the 2018 Fall Economic Statement for the blue. That's the amount that's actually being spent on healthcare in Ontario. And then the green was their own projections. And this was before COVID. And maybe people in Alberta are thinking, well, Ontario, haha, too bad, buddy. But the problem is it's typical of Canada. So Schadenfreude is not going to get us very far here. Look at this rate of increase. How on earth is that meant to continue? And how far is it meant to continue? Until health takes half of program spending? Until it takes 2/3? At some point, we just have to admit we've got a problem. And even if if it was delivering better than it is, this would still be very ominous. And apparently great minds think alike, because the Fraser Institute just released yet another study of the mediocrity of our system. There was a piece in the Toronto Sun just 3 days ago by Laurie Goldstein talking about the study is called Less Ottawa, More Province, saying decentralized federalism is the key to healthcare reform. Well, it's part of it, but it's not the whole thing. So despite high expenditure, Canada ranks 26th out of 28 in the number of doctors in the OECD, 2.8 per thousand, 25th out of 26 in acute care hospital beds, 24th out of 28 in psychiatric beds, 21st out of 24 in MRIs, 10.5 per million people, 22nd out of 26 in CAT scanners, 17th out of 24 in PET scanners. Our medical wait times are the longest in the 10 comparable countries with universal healthcare systems. These are terrible numbers. These are not, hooray, we're the best. These aren't even, well, could do better, right? This isn't like getting a C in school. This is like getting an F in school, except getting an F in school, it just makes your parents mad. This is a much bigger problem. And it's arisen because of half a century of trying to do the same dang thing over and over and expecting a different result. And those people, and they're still quite numerous, who keep saying it's fine, except we're not spending enough money. It's like people saying the Titanic is fine, except it's not floating enough. And then when you say that, they're, money's not everything. And I suppose money isn't everything, although you should certainly send some to Danny and the EEA. And if you've got any left over, send it to me, because it does sort of help you eat and live and things of that sort. But if money is so unimportant, why is everybody's solution to the healthcare crisis, except the Fraser Institute's perhaps and mine, more money? That's what makes it sound like money is important. But in the sense that money isn't everything, our healthcare system isn't free in a very important non-financial way. And that's what happens to people who get stuck on waiting lists. They don't just suffer, they lose quality of life they never get back. Somebody who's waiting for a hip replacement or cataract surgery and can't interact with their grandchildren, can't just put the grandkids, take the battery out, wait 2 years, and then be there for them as they're growing up. Other people die. The system doesn't just consume immense amounts of money. It consumes people's lives. And one of the reasons that it does this, and that it wastes the time and effort and idealism of medical professionals, is that it treats your time and your quality of life as of no value. And I mean that literally. I'm speaking as an economist here. If you think about a private firm, they need to think about the fact that if customers get frustrated, they'll go somewhere else. If you irritate them, if you make them stand in long lines, if you give them bad products, they leave and you lose money. So other people's problems in the private world are your problems. You must put a dollar value on their time, because if you make them wait, they leave and you lose sales. But maybe not even from the point of view of the hospital or the doctor who might want to actually treat people, is probably why they went to medical school. But from the point of view of the hospital, and particularly of the Ministry of Health, the best patient is the one that never shows up. There was actually a Yes Minister episode where they were going to give an award to the most efficient hospital in Britain. And the problem is, when they ran all their metrics, the most efficient hospital was one that had no patients. It literally hadn't opened and let people in. But this is, the healthcare system wants you to go away, and it doesn't care why you go away. It doesn't care if you go away because you were frustrated. It doesn't care if you go away because you're dead. It just cares that you go away. And one of the problems with the defenders of healthcare, and this isn't a conspiracy theory, but it's a fair observation, they don't have this problem. They don't wait. If you walk into a hospital emergency room and say, here is the minister's health card, then boom, they are immediately whisked into treatment. They do not sit in the waiting room for 12 hours, nor do journalists and activists. As soon as the hospital realizes this one means bad publicity, they bump them up without saying anything. And surprisingly often, doctors can tell you this privately, though they are not allowed to tell you it publicly. But people, including staunch defenders of Canadian public health care, pull strings to get faster service for themselves and their loved ones, for their staff, for their friends. They make phone calls to doctors they know. It's astonishing the amount of that comes out of ministries of health. There's a one rule for me, another for thee principle. And self-important people have trouble recognizing when they're cutting themselves a bigger piece of the pie. They just think they deserve it. And these sorts of problems are not going to go away because we wish they didn't exist. To be annoying and quote myself, back in 2012, I wrote a piece about hospital food, which I actually thought was quite funny. It had lines like, why is it when you're visiting someone in hospital and their meal arrives, the stench makes you gag and try to claw open a window? And I asked, why is the soup in a hospital worse than what you'd get if you had some teenager open a can of Campbell's soup, dump it into a bowl and microwave it until it was lukewarm? Because it really is. And this is at a time when people are having trouble eating because they feel terrible and they're sick. Well, curiously enough, the response to this column was that
What are you doing 30 along this fucking road?
A local hospital got in touch with me to say, no, you're being unfair to us. We have made our food a lot better. And so I said, okay, I will come and look at your food. And then I wrote an article saying, wow, the Queensway Carleton Hospital in Ottawa has really done a wonderful job of making the food better. This is some time ago now, but after acknowledging what they had done and how patients appreciated it and all kinds of things like that, I said, consider that the Queensway Carleton Hospital had to spend money on new equipment, and if the new system didn't work, they'd have been over budget and unable to serve food. And they had to retrain staff who in the old system just had to plunk the same stuff on the same ugly tray in the same configuration for everyone. And some took to it more readily than others. And they had to convince suppliers of mechanically standardized food that the medical benefits of scientifically determined portions were lost if patients couldn't choke them down. And it turns out, luckily, the Queensway Carleton Hospital was due for a food preparation refit anyway. That was in the global budget, and the new equipment turned out to cost less. But the point is, for them, it was all risk and no reward. Making patients happier by serving better food produced neither a larger budget for the hospital nor raises nor bonuses for staff. And that is a chronic problem in Canadian healthcare. Making patients happier, making patients healthier doesn't bring them rewards. It doesn't make their life easier. I don't just mean, they don't get perks. I mean, the hospital doesn't get more money. The doctor doesn't get more money in order to expand the practice and continue to do the things that are working better. The part of, we talk about the invisible hand in the marketplace that encourages cooperation and productive activity. Well, somebody said there's also a visible foot, right? It boots out the firms that do it badly. But our system doesn't do that. It freeloads on the virtues of doctors and nurses and other healthcare workers and patients and everybody to somehow make the system work, not by reinforcing its strengths, but by fighting its weaknesses. And sooner or later, the weaknesses grind everybody down, including the taxpayer. And there's a line that I have always treasured because it comes from the greatest Canadian ever, Tommy Douglas. I think the greatest Canadian ever was Alfred the Great, but Tommy Douglas gave us free stuff, so this is meant to be just the best. In an interview in 1982, he said, when we began to plan Medicare, we pointed out that it would be in 2 phases. The first phase would be to remove the financial barrier between those giving the service and those receiving it. The second phase would be to reorganize and revamp the delivery system. And of course, that's the big item. It's the big thing we haven't done yet. I mean, he was in politics in the 1940s. And in all this time that he was promising us this great new healthcare system, he'd never figured out how to do it. Talk about fatuous. He knew how to destroy the existing system and eat up the seed corn of the really well-functioning Canadian system that was in place in the 1940s in Saskatchewan, the 1960s in Canada. But he didn't have a plan to make it work. He just decided to do it in hope. And then 16 years later, he's like, well, I still haven't had an idea. Maybe somebody else. Has anybody got an idea? That's no way to run a railroad. And it's certainly no way to run a healthcare system. And it reminds me of a line from Pogo when Mole has some elaborate intention and somebody says, okay, what's your plan? And he looks at them in amazement. He goes, a plan? You're right. I'll need a plan. Yeah, you sure will need a plan. And one of the things that struck me about this line from Douglas is it was quoted by Michael Decter in Maclean's in 1998. So 16 years later, and of course, it still hadn't happened. And Michael Decter, of course, is like this really smart guy who knows everything, right? He's a Harvard-trained economist. He is president and CEO of a portfolio management firm. He was deputy minister of health for Ontario. He was cabinet secretary in Manitoba, and he's a well-recognized speaker on these issues. So you'd think this guy would realize that Douglas had said something exceptionally stupid. But if so, he didn't mention it. It seemed to him that this was the idea, this was wisdom, that 30 years after we wrecked private care, we still have no idea how to make public care work, but that's just a bagatelle. It's bound to come to us very soon because we're us. And if not, maybe we should get a deliverologist. I don't know if deliverology is still a thing. Imagine thinking there's a specialized science of making stuff you wished for without any idea how to produce it suddenly appear. And then you hire deliverologists. The Trudeau people were into deliverology at one point. It came out of Tony Blair's Britain, but I think they sent them all home again because they couldn't deliver. Irony can indeed be ironic at times. Now, by the last time I was out in Alberta before COVID shut it all down, I saw somebody wearing this T-shirt, which absolutely cracks me up. And so if you're too cheap to send me money, you could buy me one of these shirts. I do, in fact, have CDO, which is why I have hundreds of pages of notes about the failings of Canadian healthcare collected over decades. But I somehow resisted cramming them all into this speech, and you can thank me later because I'm not going to interrupt myself now. But I did start scrolling through one of the files, and I found this great line. Emergency room overcrowding is a big reason fewer than half of all heart attack victims receive life-saving drugs within the recommended 30 minutes of arriving at hospital, a landmark national study has found. Only 44% of victims arriving in emergency rooms across the country received clot-busting drugs in time. About 20% waited an hour or more. And so even the people who are really sick, you're in an ER, you've had a heart attack, and they're like, okay, buddy, if you could just like not die, we will get you eventually and give you this vital, urgent, life-saving drug. But for heaven's sakes, line up and stop whimpering. And this was actually a story that was in the Ottawa Citizen in 2005. So that was 16 years ago. Think how many people have not received timely treatment in an ER and have died sooner and have had lower quality of life because of that. And that story somehow blamed patriarchy. It said women wait longer than men, but it didn't blame the system. And that's the thing that we have to start doing. It also had the same file. I had a line from Brian Tobin, who said, if the 1990s were a time for fighting deficits by shrinking governments, this decade, that's the 2000s, will be known as an era in which governments either reinvent the delivery of healthcare or abandon it as unsustainable. That was written in 2003. And so did they reinvent the delivery of healthcare? Nope. Did they abandon it as unsustainable? Nope. It's like a line I heard once about Philip II of Spain, that no experience of the failure of his policies could shake his confidence in their essential excellence. And of course, bear in mind that Tobin, former federal cabinet minister and premier of Newfoundland and Labrador, didn't experience its failure. He wasn't the guy waiting for the life-saving drugs. And there's Joe Clark. Remember him scribbling out Stockwell Day's sign in a debate about healthcare. He got surgery at the private Shouldes Clinic. And when he was asked about it, he gave a classic response. Had I needed to go to the public system, I probably would have waited longer. So you can, but he can't. And Jack Layton also went to the Shouldes Clinic, and then they tried to say it wasn't really private, but of course it was. And here's another from the same year. So this is 2003 again. Jeffrey Simpson is writing, provinces are scared by healthcare costs. They do not know how to control them. Provinces can demand more and more money from Ottawa while understanding that these sums will never be enough. But provincial governments cannot level with their publics because they're scared stiff of the reaction. Leveling with their publics would mean saying, you cannot have the existing healthcare system with its spiraling costs, plus maintain all other programs at today's level of taxation. You, the public, must choose among higher taxes, less spending on everything but health, or less public and more private spending on health, or your governments can plunge back into sustained deficits. But Simpson added, the Canadian public, alas, has been conditioned to believe the contrary. Their politicians of every stripe, federal and provincial, and their royal commissions and task forces have told them something else, something that people desperately wanted to hear, that they could have more of the same without paying more or sacrificing other programs. The people were misled badly. And then he adds, the Canadian Institute for Health Information reported this week that provincial healthcare spending had grown by 6.4, in the last 2 years had grown by 6.4 and 6.8%. And it's 38% of all provincial program spending, up from 32.7% just 5 years ago. In Ontario, 43%, in Manitoba, 42%, and so on and so on. So what have we done since these kinds of warnings were issued? We've spent a lot more money. We've rushed from pillar to post on the problem of how to do the incentives. Another Soviet story. If they told nail factory to produce nails, if they rewarded them for a weight of nails, the factory would produce one enormous nail. If they rewarded them for the number of nails they produced, they would churn out pins. And you couldn't really fix this problem. Or a window factory. If they said make a certain weight of windows, they produce windows so thick you couldn't see them. If they said produce so many square meters of windows, they'd produce panes that shattered while you were trying to transport them, never mind use them. And that wasn't because the factory people or the planners were stupid. It's because this kind of planning always inevitably rewards the wrong stuff. And one of the things it rewards is idiotic rhetoric. For instance, this line here, there's no mutual exclusivity here. You can have lots of innovation and be within the Canadian Health Act. So who uttered that line? Why, that would be Tony Clement, Ontario Health Minister in April 2006. And yet the Globe and Mail had written 2 years earlier that a study by the BC Orthopedic Society and the Arthritis Society of BC revealed that in BC, the average wait for a knee replacement is 18 months. For a hip replacement, it is 11 months. More startling still is that every 6 months, the number of people on those wait lists is growing by 13% and 9% respectively. So here's a depressing thought. Suppose you're 60 and suppose you hope you're going to live to be 80. If you need a knee replacement and you have to wait 18 months, that is nearly 10% of your remaining life, probably the more active part of it. And because your knee doesn't work, it's hard to work out, that is cutting your life expectancy. And no one will ever record on your death certificate, died of waiting list. But this is what happens to people. It certainly contributes. Now, I said I wasn't going to empty the entire file on your heads, and I won't. But I did, while preparing this talk, I tripped across a website, sort of things on the internet that should have been yeeted out the window. It was a warning of the nightmarish consequences if Stephen Harper became prime minister. And one of them was, quote, private healthcare clinics would spring up all over the country, giving the wealthier quick access to health procedures while draining the public system through reimbursements for those procedures, end quote. But of course, Harper did no such thing. And many of you know I'm very disappointed with Stephen Harper. He was a libertarian who acted like he had forgotten everything he knew about economics the moment he got political power and left office not having done so many things that he could have done. But nobody else has done them either. Even though the evidence has been pouring in for decades and has been brushed aside, I think we're done with that plan. I think in this respect, I think COVID hasn't so much caused a problem, though it has worsened it in some ways. What it's really done is reveal how bad it is. And we're going to hear later on from Brian Day about, how determined the system still is not to face up to the problem, let alone try and fix it. The idea that private clinics might relieve some of the pressure instead of draining off the talent is one that the non-economists who think they're economists in government and the world of activism just can't get rid of. They have no idea how markets work and they're not interested, but they know it's terrible. And I also remember way back when I worked at the Fraser Institute, back when both ears worked. And that was when they were starting to try and measure wait times. And the result was an indignant denial from all the usual suspects that there even were wait times, along with vicious kicks at our motives. And then after that, they said, well, okay, there are wait times, but Fraser's measuring them wrong. And then they said, okay, maybe that does mean we should measure them instead of just going, shut up, shut up, shut up. And then they started promising to make them go away through more money and magic mind beams, and then, but never by restructuring the system. And so we have now had 20 years of governments promising to make wait lists get better, and they haven't. And at some point, it just becomes overwhelming that something is wrong. At the moment, apparently all anyone can think of in healthcare is COVID. But if they ever get over that, they're going to find out that the waiting lists have got a lot longer for the so-called elective surgery, as if getting a hip that works were some kind of lifestyle choice, as opposed to a very important medical procedure or a bypass operation. And the thing is, you don't actually have to wait because the Fraser Institute is still putting out these waiting your turn studies. They keep getting more and more sophisticated. And they say that by 2020, the first wait from referral by a GP to consultation with a specialist increased from 10.1 weeks in 2019 to 10.5 in 2020. That's 184% longer than 1993, when it was just 3.7 weeks. And then there's another wait from the specialist consultation to actually getting treatment. And that one had gone up from 10.8 weeks in 2019 to 12.1 in 2020, 116% longer than 1993, when it was 5.6 weeks, and 4.3 weeks longer than what physicians call clinically reasonable. I mean, not everything has to be treated tomorrow. That's fair enough. But waiting 3-4 months to get the treatment after having waited 2.5 months to get the diagnosis, that's a big piece of your life. You don't wait 6 months to get a vacuum cleaner. And people would say, well, healthcare is more important. That doesn't mean you should wait longer. If you had to wait for a vacuum cleaner, but not for an operation, you'd be better off than the reverse. What's more, the Fraser study estimated that across the 10 provinces, the number of people waiting, the number of procedures people are waiting for is 1.2 million. So assuming that the people are waiting for one each, that means over 3% of Canadians are currently on a healthcare waiting list. 1 in 33 people is currently on a waiting list, despite all the ways governments use to try and keep them off waiting lists, treatment being one of them, but not counting out waiting them. There's all kinds of others. And again, we're not alone here. It's not like we've been cursed by the anti-Canadian fairy or something. There was a story on Wednesday in Britain's Guardian, in which they warned, implement Plan B winter measures now or risk NHS crisis, Johnson warned. And this is like the lockdown crowd going, lock everybody down, lockdown forever. Yes, sure it is, strap on more masks. But if you slog on down, it says, if NHS Confederation head fears efforts to tackle backlog of 5 million patients will be derailed. 5 million people are waiting not for treatment for COVID, but for all kinds of treatments. In fact, the number of people waiting for hospital treatment in England is now 5.7 million because the backlog of care has worsened during the pandemic. It's worsened, but it wasn't created by the pandemic. And the British system, like virtually every system in the world, has a more flexible private component than ours does. And so again, there are still people saying it's all fine, just pump more hydrogen into the flaming Hulk, but I don't think it's going to happen. Again, I'm going to quote myself because I'm just an annoying person, but also because this is from the May 2003 Ottawa Citizen. So I told you so, and I told you so way back when, and I told them so. And I said, Health Minister Tony Clement promises a major overhaul of Ontario hospitals in the wake of SARS, right? We had this unexpected emergence of a respiratory coronavirus that came from the Far East, and it showed us that our hospital system was badly designed. So Clement says he's going to fix it to, quote, to make sure that as a result of what I call the new normal, our hospital system continues to be of the highest quality, end quote. And you notice the classic politician verbiage, continues to be. So nothing is wrong and we're going to fix it. And again, this isn't some, left-wing big spending pinko. These are the Harris Tories, the slashers. And in response to this, I wrote, so will we move away from a huge, rigid, centralized state-run system? Yes, to another huge, rigid, centralized state-run system. It's one of those change within a framework of continuity deals. And part of my point here was the security experts' distinction between brittle and ductile systems. As Bruce Schneier said, there are two basic approaches to designing anything. One is to put your time, attention, and resources into making sure nothing can go wrong. And the other one is to put them into making sure the system can recover from failure. And my point back in 2003 is that giant hospitals are brittle. They gather all the illnesses and all the experts in one place, and they're all the same, especially because the Ontario Tories consolidated them. Like, these guys were such free marketeers that they thought gigantic central planning units were the best. They were even going to shut down pediatric cardiac surgery at the Children's Hospital of Eastern Ontario and put it all in Toronto until SARS started shutting down hospitals and putting medical people in quarantine. And this was a warning. And again, I don't want to steal people's thunder, but one of the points that I've heard Brian Day make is that if you have private clinics that specialize in one or two procedures, then they, even in a case where there's something like COVID, they have much less serious infection control problems. They've got the protocols in place, but it's much easier to manage. And that way the hospitals can focus more, the big ones, on what they do best, instead of having the hospital have everyone come in. So if the COVID problem gets overwhelming, all the procedures get delayed or stopped. That's a ridiculous way to run a healthcare system, and it's exactly how we do it. So I'm going on in this column. I said, so what would I do instead of big hospitals? I said, I wouldn't do any one thing, except let other people do lots of different things. I didn't favor telecom deregulation because I foresaw the internet, but because I didn't. If I knew what freedom would produce, I wouldn't need freedom to produce it. I could plan it centrally, but I don't. What I do know is that central planning is the ultimate brittle solution. If everyone is doing the same things right, they're also all doing the same things wrong, which would be dangerously brittle even if there were one right thing to do, which there isn't. It's not a flaw in markets that some restaurants serve beef and others are vegetarian, instead of all stuffing the Canada Food Guide down our throats. And then I went on to say we should even, have freedom in terms of who gets to study medicine and practice it, because it's better to have decentralized mistakes being made and corrected by patient satisfaction than to have the government decide how many doctors there should be. And if they get it wrong, there's nothing anyone can do and nowhere you can hide. If they either produce too many doctors, so there's too much billing and the tax system's in trouble, or they produce too few doctors and generate waiting lists. There's nothing anyone can do if the state imposes fee for service and then suddenly goes, oh no, we need group practices. And you've seen the planners trying to go back and forth with this, because with fee for service, you get the problem where they produce all the pins. The doctors are just cranking people through. If you get the group practice sort of set fee, then they spend a lot of time with patients, but they don't see enough patients. All of this would be fixed if we had customer satisfaction driving the medical care system. But instead, you got Tony Clement trying to figure out what every nurse in Ontario should do. How could he possibly know that, even if he had better medical training than he does? And then I warned, what if some unknown respiratory disease bursts loose from the Far East? Socialism guarantees that we all go together when we go. It's no way to run a health system. And of course, it's exactly what we did and said. And so we are now in a position where this obsession with central planning with the impact of COVID means waiting lists are so long that I think people are going to finally admit we've got to do something different. And so the question is what? And that's why we're here. You know, what we're not going to do is peddle these myths or even acquiesce in them. We are not going to let people pretend the system is working, that it's the envy of the world, that it's free and just needs tons more money, that it's our way or the American highway. That's just mediocrity. And one of the things that we should not tolerate as Canadians, and we're too often told to tolerate, there's mediocrity, this famous passion for the bronze. You know, years ago, I took to saying that a slogan for official Canada might be, yes, we can't. Luckily, we don't think that way. We think we can do better. That's why we've invited all these other speakers and why I'm now going to stop talking and let them start. Thank you.